now I have the pleasure, I feel like I've said that a lot today, and it's actually been very, very sincere. Like, I've been so excited to introduce each one of these people. But Neil has a special place in my heart because he actually changed so much of how I practice and how I ended up to where I am today. So Neil O'Connell is a senior lecturer in physiotherapy at Brunel University in London. He divides his time between research and teaching, and previously worked extensively as a musculoskeletal physiotherapist. Neil's main research interests are chronic low back pain with a focus of evidence-based practice, and he's published extensively in this area. Neil is a member of the editorial board of Cochrane's Pain, Palliative and Supportive Care, shortened to PAPAS group, the Journal of Pain, and is a senior commissioning editor for the Pain Science blog Body and Mind. He was a member of the Guideline Development Group for the UK's National Institute of Health and Care Excellence, the NICE guidelines, in 2016 for the management of low back pain and sciatica, and contributed to the NICE quality standard on that topic. So I'm very excited to give you Neil O'Connell.
Am I on? Can you hear me? Fantastic. Did you have a nice lunch? Yeah? I'm a little bit worried now, having stepped up. First of all, thank you, Rajan, for having me back. It's such an amazing treat for me to leave London and come to San Diego, where the sun actually shines. So that's lovely. But I'm a bit worried because I just don't know how to follow the tension and excitement of the raffle. And but I'm very happy to be asked to do that, and I'm happy to help ease you into your post-lunch carbohydrate comas. So I want to talk to you about low back pain guidelines. A lot of people talk about guidelines and evidence-based practice, and a lot of people know a lot about it, but a lot of people have quite substantial misunderstandings about what guidelines are and how they come about and how we might use them. So I want to talk to you about, well, what have clinical guidelines ever done for us in the world of low back pain? As Sarah said, I've done a few different things, but I put this up so that you can see my biases, really, and to just declare my interests. I was the senior commissioning editor of Body and Mind, but rest in peace, Body and Mind. We've had to lay that to rest now, sadly. But I did work with NICE on clinical guidelines, the last back pain guideline, and that was a real learning moment for me. It's a big privilege because it's our national guideline on how you manage this massive problem. And it was an adventure. And it was a learning exercise. It's something I'm very proud of, actually. I'm proud of the guideline as well. But it's made me look differently at evidence-based practice, perhaps, than I did before I got involved in that process. So the title of the talk comes from a favorite film of mine, which is The Life of Brian. And at one famous point in The Life of Brian, the Judean People's Front exclaim, "Well, what have the Romans ever done for us?" Which is where I got the title for the talk. And I'm not going to mention that again. I'm just going to come back to it at the end. What have they ever done for us? If you've got back pain, and let's be honest, most of you have already had it, and those of you who haven't are likely to get it, and those of you who don't are abnormal, then you've got no shortage of treatments that you can choose from. Just Google it. I did this last time, I know, when we talked about pain management. But we've got all the options. We've got options we can buy on Amazon. We've got opioids. We've got medication. We've got an awful lot of experts who are very confidently telling you they can fix this problem. And we're so lucky to have that, aren't we? Because now we've got that, low back pain isn't much of a problem for society at all, is it? Got all these options, problem goes away. Or maybe it doesn't. In fact, historically, we've never been short of guidance for how you treat back pain. This, as far as I know, is the first documented guidance on the management of low back pain from the Edwin Smith Papyrus, which is an Egyptian papyrus from the 17th century BC. Imagine that. So translated, and this is not my translation, it talks about the examination of someone with low back pain. If thou examinest a man having a sprain of the vertebrae of his spinal column, thou shouldst say to him, extend now your legs and contract them both. He contracts them both immediately because of the pain he causes in the vertebra of the spinal column in which he suffers. They weren't good for brevity, the Egyptians, right? Diagnosis. Thou shouldst say to him, one having a sprain in the vertebra of his spinal column, an ailment I can heal. Now that's hubris, I reckon. But anyway, treatment. Thou should place him prostrate on his back, and that piece of papyrus runs out, and we'll never know. We'll never know. We'll never know what the treatment is. No, for real. So let's move a bit further forward then. This is the very wise Roman academic Pliny the Elder, 23 to 79 AD. Sexual intercourse is good for lower back pain, for weakness of the eyes, for derangement and depression. Well, that's pretty good, right? I mean, there's Pliny the Elder already recognizing that exercise is helpful, but no particular exercise is more helpful than another, so maybe you should do the exercise you love. Right? Let's move a bit further forward to the Greeks. Galen documents the case of Sophocles. Sophocles was promising to set Diodorus' crooked back straight. So he piled upon him 3 stones, each 4 feet square upon the hunchback's spine. He was crushed and died. But he has since become straighter than a ruler. This is the first documented example of using a surrogate outcome measure that isn't awfully patient-centered, right? And the last historic one I'm going to give you, we're going to bring you all the way up to the Herbal or General History of Plants, very much enlarged by John Gerard from 1636. And there's a, I find, somewhat disturbing recommendation found at the bottom here. Let's see, it's for comfrey root. The slimy substance of the root made in a posset of ale and given to drink against the pain in the back, gotten by any violent motion, such as wrestling or overmuch use of women. John, obviously there before the Me Too movement. Doth in 4 or 5 days presently cure the same, although the involuntary flowing of the seed in man begotten. For anyone who's interested in that and thinks that's a side effect they would like to experience, you can get comfrey ointment online. And you can see why Christopher looks so pleased with himself. I joke, of course, but actually what these things tell us is we're constantly seeking a solution for this problem. And we think about what might be causing it, and we come up with our ideas, and we develop our treatments, and we make recommendations. This rather ugly slide comes from the Global Burden of Disease study, and you'll have all seen the data from this study before. And this is a ranking of the conditions that cause the most years lived with disability globally. And look at the top. We've got low back and neck pain. And the problem is, over time, because this is a constantly updating, massive epidemiological study, that isn't going down, it's going up. And that's an odd thing, because we must just juxtapose it against how much we spend on treating low back pain. So this is personal healthcare spending in the USA for conditions around 2013. And in 2013 in the USA, you spent $87.6 billion on the management of low back pain. And the annualized rate of change is a $6.5 billion increase. That is phenomenal. So we have a problem which is the leading cause of disability-adjusted life years in the world, years lived with disability, sorry. Despite the fact that we are spending more and more money treating it. Now, the only logical conclusion to that is at least some aspects of the industry, and we're all part of the industry of treating low back pain, are parasitic. People with low back pain are the host. There's loads of money being made out of this condition. But at a population level, things aren't getting better. So maybe we need some guidelines. Maybe we need to look hard at the evidence and try to pick those treatments that are more likely to be offering value. So why do we need guidelines? Oh, sorry. We need guidelines to summarize and synthesize what is an evolving body of knowledge. There is loads of research being done on low back pain. The number of clinical trials in low back pain and large, high-quality clinical trials is on the increase. And we need to constantly update our knowledge about what best practice looks like. We need to promote for people evidence-based clinical practice. We need to reduce, and the word unwanted here is super important, unwanted variation in clinical practice. Personalized care demands variation in treatment, but it's the unwanted variation that we want to try and eradicate. We want to improve the quality of care, and we really do need to improve the efficiency of care. And we want to satisfy the need for transparency and accountability. We want to use a process where there's a clear audit trail to where we got to those decisions, because we have an industry and all of us have our vested interests. We all pay our mortgages because people get low back pain. You know, we all buy our sports cars. Well, probably not in this room so much, but if I was in an orthopedic surgery conference, we buy our sports cars based on the treatment of low back pain. So we need a process that's genuinely accountable and tries to reduce bias. So how do you create a clinical guideline? Or how should you create a clinical guideline? Well, the first thing is you have to do a very detailed exercise in identifying and refining the subject and the scope. What do I mean by low back pain? Am I including people with leg pain? Are we only talking about non-specific low back pain, or are we broadening that out? What interventions are we interested in reviewing? What interventions will be excluded from our guideline? That will possibly lead to inconsistencies between guidelines. Once we've identified the scope of the question, we need to do the hardest part, which is to convene and manage a guideline development group. A guideline development group is a group of experts who are going to sit in the room and they're going to look at all the evidence that's presented in front of them, and they're going to have to turn that evidence into clear, deliverable recommendations for the delivery of care. So you want to pick those people carefully, and we'll come back to that in a minute. We need some process of sourcing and assessing the evidence. That will normally consist of a huge range of de novo systematic reviews of RCTs and sometimes observational studies for all these interventions. And in low back pain, that is a massive undertaking. We need to then decide what that evidence actually means. And I've been teaching an evidence course the last couple of days, and I think one of the things that really came clear is, even when you got the answer from the trial, there's still a bit of interpretation about what it actually means for practice. So we need to translate that evidence into clear recommendations. And then when we've produced our guideline, it's not enough for us to didactically push it out into the world. We need to consult stakeholders, including patients, including people from all the clinical disciplines, to get their view on what those recommendations mean and how they would change them, and possibly adapt the guideline in light of that feedback, and sometimes not. Excuse me. So imagine you're on a guideline group now. So you sat around a table and you've just been shown a systematic review with a bunch of evidence. And the evidence says to you, I've got a handful of quite small, not very good quality clinical trials that suggest that this treatment improves pain on average compared to placebo by 0.5 point on a 0 to 10 pain scale on average. So that's the value of the treatment, or our best estimate of it. Now you're faced with a choice. You can make no recommendation about that treatment. You can say, that's not big enough. Don't use that treatment. Do not offer that treatment. You might say, do not routinely offer that treatment. Well, that's a really interesting one. You know how whatever system you produce, someone will learn how to game it, yeah? If you say don't routinely use a treatment, then any clinician who wants to use it says, well, none of my patients are routine, and carries on using it anyway. So you've got to be careful with language. You might say, consider using this treatment. Now, what consider means is, there's some not very good evidence that it seems to help a little bit, and maybe it's worth it, but we're not that convinced. Or finally, at the top of the pyramid, you've got offer. And offer reflects, yes, we are sure that this treatment, without any real uncertainty, is delivering clear and meaningful benefit, and therefore it should be offered to people with this condition. So go back to my 0.5 point from a few dodgy trials that are slightly biased and are likely to have inflated the actual true effect. 0.5 point on a 0 to 10 pain scale. Put your hand up if you would say, I can't make a recommendation based on that. There's not enough evidence. I've got 3 or 4 small trials. Oh, we've got 1 or 2. Brilliant. There's really no right answer to this. Put your hand up if you would say, do not use that treatment. Do not use it. It's trivial effects. I don't see why we would use it. You've got trials that are designed to inflate an effect and yet the effect is tiny. We had one man with his hand up at the back there. Put your hand up if you'd go with do not routinely use, knowing that that means that anyone who wants to use it will find a reason to use it, right? Put your hand up if you would say consider using that. Okay, a few more. Put your hand up if you'd say offer it. Offer that treatment, it's fantastic. It's definitely worth offering. Hang on a minute. Put your hand up if you didn't put your hand up. Cowards, cowards, cowards. But that's the challenge. That's what a guideline group is trying to do, often in the face of substantial uncertainty. When you convene that guideline group, it really needs to be multidisciplinary, right? It can't, guidelines developed by single professional bodies where the panels consist only of people from a single professional body, that's not a great way to go about this business at all. The reason you need multidisciplinary participation is because you need that expertise, right? If someone's doing radiofrequency stimulation or involved in spinal fusion or disc replacement or opioid prescription or physical therapy, you need their nuanced understanding of these interventions to interpret that evidence, that subject-specific expertise. You need it because it's multidisciplinary teams that people with back pain are exposed to, so they need to be represented. You need it because in the end, when you publish this guideline and you haven't involved people, if they don't like it, they will reject it out of hand, and the guideline is completely pointless. But by multidisciplinary participation, we are not just talking about clinicians. A guideline that does not include people who experience that condition and experience clinical care just isn't worth the paper it's written on. You need patient representation, and not in a tokenistic way, but a full, balanced voice at the table. And when you bring that multidisciplinary group together, it needs to be very clearly established at the start that there are no leaders in this room. Everyone's voice is an equal vote. The real reason, of course, you need multidisciplinary participation is because clinical guidelines are a political process, right? Everyone wants their territory protected because that's how industries work, professions work. So you need a balance of those interests to try and avoid it being too busily pushed into the interests of one professional group. And I'll give you an example of how that can go wrong. This is a very fresh review of financial conflicts of interest in the guideline panels at the peak of opioid prescribing. So they had a red flag checklist that they applied to guidelines on opioid prescribing. It was things like the sponsor is a professional society that receives substantial industry funding. The committee chair has a financial conflict. Committee members have a financial conflict. Committee stacking that would preordain a recommendation regarding something controversial like opioids. No involvement of methodologists or research experts in the process. No external peer review. No inclusion of non-physician experts, patient representatives, community stakeholders. Pretty clear. You can see how each of these things might produce a conflict. 13 guidelines on opioid prescribing between 2007 and 2013. Across those 13 guidelines, they found 43 red flags. That's an average of 3 red flags per guideline. This isn't serving people with pain. This is very, very dangerous. Of course, if you're using a guideline as a clinician, you probably want to know if it's a good one or not, if it's been done well, if you can, at least to some extent, put faith in it. And we now have, and this is an internationally recognized quality assessment tool for clinical guidelines, called the Agree To tool. You can download it for free. There's a manual for how to apply it as well. So you take a guideline and you look through different domains. Were they clear about their scope and purpose? Have they clearly outlined and attended to involvement of all stakeholders, including patient groups? Have they used methodologically rigorous approaches to synthesizing the evidence? Have they presented it in a clear way so that the audit trail between the data and the decisions, the recommendations, is clear for people to see and understand? Have they made recommendations that are actually applicable in practice, that could be delivered in that clinical community? And was it editorially independent, or is it full of these red flags we were talking about? Ivan Lin from Australia a couple of years ago did a systematic review of musculoskeletal clinical practice guidelines and found that on the whole, they were pretty low quality. And I'm not doing this as a fact of self-promotion, but the only one that they thought consistently met high quality standards was the 2016 guideline for low back pain. Go us. But it was nice to see because there was a process, and if you go on the NICE website, you can download 3,000 pages of documents that explain how we get there, if you've got nothing better to do. So I think about the NICE process for back pain, and you think about, I want to be an evidence-based clinician. I want to know what the evidence tells me about low back pain. Let me give you a sense of the scale of the task. We had 23 new systematic review questions, and we could answer them with 22 new systematic reviews. That means in the end, we screened 43,000 records and 734 papers were reviewed. We received 720 stakeholder comments. People really care about what recommendations are made. And 297 internal review comments from NICE. It took us 3 years to produce the guideline. It runs to 3,600 pages, and we made 41 recommendations for practice and 7 recommendations for future research. And the reason I show you that is just to try and give you a sense of the scale of the task and why guidelines might represent a proxy and a shortcut for you guys when you're trying to make sense of such a vast body of evidence. And after all that work, we came up with this picture. It's pretty, isn't it? But, I mean, most of you will be familiar with the recommendations, and I don't want to dwell on it because this is just our guideline. I think it would be interesting more to look at what the recommendations are across a number of different guidelines for low back pain. Because actually, it's not always consistent. If we look at the UK guidelines and then we look at the US, the APA guidelines, and you look at the Danish guidelines, you'll see differences. There are differences in the recommendations for spinal fusion. At NICE, we said, do not use spinal fusion. Do not offer it unless it's part of a new RCT that can actually reduce the current uncertainty about the risks and benefit. But other guidelines will use the equivalent of a do not routinely use or do not use first. But the evidence for spinal fusion, there is some evidence of some benefit, but it is far from compelling. We said do not use any spinal injection, which made us super popular with the spinal injectors. But the evidence was appalling. It wasn't clearly better than placebo, right? But other guidelines will say do not use it first or do not routinely use it. We said do not use acupuncture because it wasn't convincingly better than placebo, sham acupuncture. Other guidelines have focused on the comparisons of acupuncture to usual care, and on that basis have said, well, you can offer it. We said you might, for a certain group of people near the end of the pathway, use radiofrequency denervation procedures. And other guidelines have said the evidence is currently inadequate. We said do not offer opioids for people with persistent back pain. Other guidelines take more nuanced positions. So why is it that if these guidelines are essentially looking at the same evidence, they're coming up with different recommendations? What are the sources of inconsistency? Well, it depends on what question you ask. We took the view at NICE that if it was possible to do a placebo control for a treatment, we wanted to know if the treatment was better than placebo, and that was our priority question. So placebo controls, efficacy trials, were the ones that we would base decisions on where they were available. Other guidelines aren't interested if it's better than placebo. They just want to know if people feel a bit better after receiving the treatment. And that will lead to differences in recommendations. We did not recommend acupuncture on the basis that it wasn't better than placebo. Other guidelines say we will recommend considering acupuncture because it seems to be better than doing nothing. The date of the publication of the guideline will make a difference because the more up-to-date the guideline, the more data it contains, and new studies may change the answers we have to our questions. The scope of the guideline may lead to different recommendations. The American guideline talks about a number of different herbal remedies. We didn't look at herbal remedies at all at NICE. The size of the effect might make a difference. So when we did our review at NICE, we established a minimal important difference threshold. The smallest effect that we would take to say, yes, that's meaningful. And our arbitrary minimal important threshold was 1 point on a 0 to 10 pain scale, which doesn't seem super ambitious, does it? If you cross the line of 1 point on a 0 to 10 pain scale decimates the field. It removes most treatments for low back pain, which is something I said to you guys a couple of years ago when I spoke. Other guidelines don't worry about a minimal important difference. They just focus on p-values, measures of statistical significance. I would argue that's not a particularly useful metric because it doesn't reflect whether you've got a treatment effect that is clinically meaningful. It just reflects whether there's a treatment effect that isn't just a function of chance. And finally, you're just going to get interpretive differences. Why is there so much scope for different groups to come to different decisions when in back pain, there's one reason. It's because the evidence is often marginal, it's often piecemeal, and effect sizes are small. If we had good, solid evidence of large effects, all groups would come to the same decision. But what we're really trying to do is navigate substantial uncertainty and quite disappointingly small effects. So that's the inconsistency. Let's think about where guidelines actually agree. Well, all these guidelines, the British guidelines, the US guidelines, the Canadian guidelines, that's covered almost everyone in the room, consistently recommend ruling out. So you do an examination, do a thorough assessment, rule out alternative diagnoses and specific spinal pathology, and offer high-quality education, including the encouragement of an early return to activity. Guidelines consistently recommend against the routine use of imaging for non-specific low back pain. Have I surprised you yet? Guidelines consistently recommend physical exercise for non-specific low back pain. Guidelines consistently advocate a cautious approach to the use of opioids in non-specific low back pain, although that's a very recent phenomenon that guidelines agree on that. All guidelines recommend considering psychosocial influences in the assessment and management of low back pain. Just take a minute. We're going to come back to that at the end. But I don't think any of that on paper sounds awfully complicated or ambitious. That would be my view. But what does practice actually look like? So my very good friend Steve Camper has just published recently this systematic review where they looked at studies of what care people actually receive for low back pain, lots of studies from all over the world, and they concluded that large numbers of patients who saw a physician for low back pain received care that's inconsistent with clinical practice guidelines. Usual care included overuse of imaging, an opioid prescription, underuse of advice and information. Suboptimal care may contribute to the massive burden of this condition worldwide. I don't know if any of you guys saw the Lancet back pain series in 2018. If you didn't, Google it, download it. It's the best summary of the current evidence to date in low back pain. And Nadine Foster wrote a paper in that where they looked at lots of different of the studies that Steve Camper would have been reviewing. I'm not going to talk through all of them, but I do want to show you some of them. In Australia, in one study, advice to patients was only provided in 21% of consultations. 67% of low back pain patients in primary care in Qatar were advised to bed rest. 54% of insured patients in the USA were referred for imaging. 56% in Italy. 60% of low back pain in the emergency department in the USA, these people will be prescribed an opioid. That's 61% in primary care. I thought that primary care would be better, but no. There are high and very variable rates of injection therapies for low back pain globally. In 2011, spinal fusion had the highest aggregate hospital costs of any surgery in the USA. That is mind-blowing. And 54% of low back pain patients in the USA in that one study were not prescribed any form of exercise or physical activity. You know, it's remarkable, isn't it? And I often think, you know, I spent 3 years with my colleagues developing that guideline, and you won't believe what they paid us to do it. Nothing, right? And for what? The reason I did the guidelines is I got so frustrated in trying to encourage clinicians to do evidence-based practice, I figured let's try some evidence-based policy, because if we can switch the money off, then people will have to stop. But that was just me on one of my grumpy days. Why don't people follow guidelines? There's been loads of research into why there's this big barrier. And Dr. Noel spoke well about, you know, it's very hard to change practice. It really is hard to change practice. Why, though? Well, there are personal factors. There are factors with the guideline itself. And there are external factors. Is it a bit worrying? This is the second talk today with a picture of a barbed wire fence on it. God, we're dark, aren't we? What are the personal factors? Well, first of all, in different fields, there's a big volume of guidelines out there. If you're a medic, you're drowning in guidelines. So maybe you just don't have time to engage with them all. A lot of people have a lack of knowledge of guidelines. 4 months after we published our one in the UK, a research colleague who I won't name went to give a talk about back pain to a bunch of medics in Cardiff, and a lot of them worked in pain management. And she asked them if they'd read the NICE guideline, and no one had actually known that it had been published. And we all gently wept. A lot of clinicians reject the paradigm of evidence-based medicine. They don't think it's offering valuable information to guide their practice. And there are issues with the recommendations if they're not acceptable to patients. Of course, we try and manage that by including the patient voice as a strong voice on the guideline development. But you still might come up with recommendations that are not palatable and acceptable to patients. What about the guideline itself? Are its recommendations genuinely feasible? Are they credible within the clinical frameworks in which we exist? Are the guidelines accessible, or are they actually stuck behind a paywall? I mean, what a ridiculous thing that would be, to charge people to see your clinical practice guideline. But are they presented in an accessible way? And then there are external factors. And, you know, I used to work in a socialized healthcare system in the UK, and it's pretty hard to implement guidelines in that environment. But in an environment where the insurance companies decide what goes down, it's much harder to change practice, because who's going to reimburse you for doing the right thing? So what are the local organization and the national organizational barriers? And do you have buy-in from the multidisciplinary team? Imagine what happens if you were a pain medic who repeatedly and regularly gave low back pain injections when a guideline says don't do any of them anymore. You know, that's pretty hard to deal with, isn't it? And there's going to be a reaction. It's going to be a process of adjustment. This study by Figg-Latham looked at osteopaths' views of a back pain guideline. It wasn't ours. It was the preceding NICE guideline. And they asked them what they thought of it. And in their analysis, they decided that the osteopaths in this study, they didn't really follow the evidence-based paradigm. They didn't follow that levels of evidence pyramid that most of us will be familiar with from research methods. They just flipped it. So at the top of their evidence pyramid was their expert opinion and what they knew to be true, and somewhere down the bottom was clinical trials and systematic reviews. I love the title of this paper. It's called Quiet Dissent. And it made me think this, because I think it's true. I don't think it's not an attack on osteopaths. I think it's true in many corners of physio and medicine and everywhere else. Evidence-based practice, most people, if you mention it, will say, yeah, I think that's a good thing. And it made me think of this quote that Jason Silvernail once said by Stephen Covey, which is that we judge ourselves by our intentions and others by their behavior. Another way of putting this is, I think for a lot of us, evidence-based practice is what everyone else needs to be doing, you know? But it's, yeah, of course we're evidence-based. So how are we going to do it then? How are we going to change practice? If we produce a guideline, well, first we need to disseminate it. Then we need to educate and train people in the delivery of these treatments if they're recommended, if that expertise isn't already out there. We need to engage opinion leaders and reach out to people who can influence clinicians on a grand scale. We need to make it easier for people to follow guidelines, easier not to order that scan or prescribe that opioid. You might use decision support systems for that sort of thing. Maybe we should mandate it. But guidelines are not a rule book. They're not a set of orders. They're guidelines. So it's not for a guideline development group to mandate what happens, but it might be for a clinical commissioner or an insurance company or a government organization to do that. What's the evidence? What's the best way to apply guidelines? Well, there's actually very little evidence that's compelling about how you change practice. But maybe we shouldn't be surprised that it doesn't just happen. This model is a really good conceptual framework for considering the complexity of us trying to recommend that people do a specific intervention. In the middle, you've got the intervention itself, what it looks like, how implementable it is, and then within that, or around that, you've got the professionals whose behavior are trying to change, their competencies, their professional role and their value systems and their identity, their attitude to change, and the philosophy that they bring to their care. But wrapped around them is the organization they work with, the skill mix, the ability to collaborate with other clinicians to make it happen, the culture of it. Do they have an evidence-based progressive culture, or are they very much stuck in their ways? And wrapped around all of that is the external societal aspects. infrastructure, buy-in of stakeholders, policy, legislation, public awareness. It's really complicated. So the idea that it would just happen because we publish a document that says this is what you should do is a nonsense. If you're trying to implement complex change, you probably want to start with a plan. I am absolutely no expert on quality improvement science at all, but this is just one framework for that. If you're thinking about changing the clinical pathway and trying to make care more consistent and evidence-based, you need to plan for it. So in this model, we'll first consider the setting and build capacity. We'll do a needs and resource assessment. We'll obtain buy-in from stakeholders. We'll recruit people to make sure that it can be delivered, and we'll train them properly. We'll develop teams to lead and manage that implementation and monitor the process. We'll maintain that structure. We need to make sure it's sustainable with repeated training and evaluation. And we need to use that evaluation to feed back in so we can continue to improve. It's going to take money, it's going to take time, it's going to take resources. But you know the thing it's going to take most is the will and the desire to do it. And that's often the hard part. This is really complicated, and it's about how you change an organization's behavior. But I'm often thinking, and this conference is very grassroots. It's a bunch of people who share some ideas about what we should be doing about pain. And they're doing stuff within the framework of which they work because they think that's the right thing to do. And in the end, in the clinic, if you want something to happen, it probably starts when you start doing it. You know, that adoption and changes in practice often start at the individual level. Frontline clinical staff often have a greater influence on what goes on in the clinic than the managers and the policymakers and all those other people. So we should probably consider what needs to be done from the bottom up. And there's no point trying to persuade people who say no to come with you. If you're trying to do that in your setting, why not try and promote it to people who seem on board? Why not recruit them into your ideas and try and enthuse them and get them to collaborate with you? And let the other people either fall behind or end up deciding they always thought that was a good idea and then following afterwards. But it doesn't start by trying to drag the reluctant with you. It starts with collecting a community of people who really want to do it. This is a lovely quote, I think, that everyone in healthcare has two jobs when they come to work: to do your job and to improve it. And that's the essence of quality improvement. Really now in the UK, this is only starting to be talked about in a serious way. This idea of it's not enough to generate evidence and guidelines. We have to think carefully how we make that convert into an improvement in the quality of care. So, I think I might even finish early. Let's go back to the People's Front of Judea. In the Monty Python film, he says, what have the Romans ever done for us? And the guy lists off this extensive list of benefits that the Roman occupation had brought them. If you're really anti-Romans, I'm sorry, it's a film, it's not my opinion. But he said, all right then, but apart from the sanitation, the medicine, the education, the wine, the public order, the irrigation, the roads, the fresh water system, public health, what have the Romans ever done for us? Such a great line. And I was thinking, well, what have clinical guidelines really ever done for us? Well, I would argue to you, and it is a dry topic and they are dry documents, they offer us clear targets for reducing waste, cost, and harm. They promote a culture shift. All of these guidelines in the end are speaking to the delivery of good information to patients, of trying to help patients to self-manage, and a shift away from a less interventionist, a less pharmacologically driven culture. All of them, consistently. And they also highlight where we've got so little evidence and the considerable work yet to be done to optimize care. We wrote a paper about these guidelines. It is worth thinking about that. When we were looking at spinal injections, that's a big industry. And I don't mean to single them out, they're just a good example. However did we get to a position where we routinely offer treatments of unknown benefit and harm? And why then would it be hard to stop doing that? There was never necessarily a good reason to do it. And we need to think hard about how we actually introduce new treatments into practice, as well as how we de-adopt those other treatments. So where do all recent guidelines agree? Well, you've seen this. Consistently do a good assessment and rule out other things. Give high-quality education. Don't routinely use imaging. Do get people to exercise. do be very, very cautious with the use of opioids, and do consider the biopsychosocial picture with everyone who walks through the door. It's really not ambitious. It's really hard to do. But just think for a minute, if we just achieved those 5 things and did nothing else, how much of the burden of this awful problem could we resolve on a global level? It's not a big thing to ask. So thanks ever so much for inviting me to and listening. I'm 6 minutes early. If anyone is mad enough to be interested in this topic, here are 2 sort of narrative viewpoint papers that we wrote outlining much of what I've said on the talk here. And if you can't get any of them because they're paywalled, let me know and I'll post them somewhere. And thank you very much.
Thank you, Neil. Okay, so we're getting some questions. I'm going to just take the top one. So from Kiri, see if I can put it up there. Oh, you beat me. Okay. How different are Scotland's low back pain guidelines?
Not very, actually, but they have their own, because they're devolved, they have their own health system. They're devolved, no, that's actually a term, I don't mean they're unevolved. Devolution was the process of Scotland having more control over its laws. You know, a bit like Brexit, but not as stupid. And damaging and nihilistic. Oh, sorry, no, I'm digressing. No, they're very similar. They were a little bit more inclusive, actually. The NICE guidelines are probably, no, they're definitely the most conservative back pain guideline that's been published to date. We recommended much less than other guidelines. The Scottish ones, from the top of my head, they did recommend acupuncture, I think, or at least as a consider. So they obviously took that route of versus no treatment rather than versus placebo.
Okay, and the next question, let's see if I can be more helpful. From Caitlin, why use pain scale for measuring effectiveness or efficacy?
Oh, what a great question. What else should I use? Yeah, so look, I guess I was simplistic there. So the 3 main outcome measures were pain, disability, and health-related quality of life. And then there was cost effectiveness as well. But don't be fooled into thinking that any of this is rationing. Cost effectiveness was not used to drive any of our recommendations. It didn't come into it because there were already other reasons to either recommend or not. So we didn't just look at pain. Pain's the one I use. So we looked at disability measured on the Oswestry or the Rowland and Morris Disability questionnaire. And we looked at health-related quality of life. And we looked at adverse events and harms. And yes, we looked at cost effectiveness, so quality adjusted life years and incremental cost effectiveness ratios as well. Pain scales are awful, aren't they? They're still what we got. But they are, they are genuinely dreadful. And I've never been to a patient panel at a conference where one of the patients hasn't quite rightly despaired at the visual analog scale. It's totally suboptimal. But, you know, how do you measure pain? Maybe you don't measure pain. Maybe there are other outcomes you want to measure, but that may be for another day.
Okay, the next question from Dave Walton. Neil, when your group extracts data for the CPGs, do you routinely extract info on inclusion-exclusion criteria too? Do you think the evidence is advanced enough to be able to make separate recommendations based on patient-level variables like sex, age, and other comorbidities?
Right, so a few questions in there, Dave. Thanks very much. But no, they're good ones. They're good ones. So yes, we like you would in any systematic review, the technical team at NICE extracted those sorts of data, the inclusion, exclusion criteria, and everything else. But you've never got enough trials that are consistent enough to really do any formal subgroup analysis that is going to be meaningful. And you'll have, I can't even see where Dave is. Dave, where are you? Ah, there you go. Where you're going to really be able to use that to make big decisions or get robust group-specific estimates. So I just don't think we're there yet. I think the other thing, of course, is if you approach it that way after the fact, what you're doing is post hoc subgroup hunting, which I like to call searching for the pony, right? Because if you've got no effect or a very small effect, but particularly if you've got no effect, then you go hunting for responders. Well, you're not measuring responders, you're measuring people who got better for any number of reasons. And you might find a subgroup, but it's a bit like trying to find a pony in a room full of horseshit. You know? So if you want to look at subgroups and if there are specific subgroups of responders, then I think that starts with the primary research. You hypothesize first, you design your trial to do that, and it's got to be big enough to detect an interaction between that variable and the outcome.
Okay, next is Linda Crawford, who's also watching from home. I'd be interested to hear the 7 recommendations for research NICE made.
Oh, God.
There may be potential researchers in the audience.
I can't remember them. Okay, so I really actually can't remember them off the top of my head. I know we wanted a high-quality, sham-controlled clinical trial of radiofrequency stimulation, denervation, because there was some promising evidence. There's no word, by the way, in clinical research more overused and abused than promising. Promising is what we like to call massively uncertain. So we had a good definitive trial of that. I think we wanted a trial of spinal fusion that would be big enough to reduce uncertainty. I think we wanted a good placebo-controlled trial of muscle relaxants because the evidence there was a bit partial. I genuinely can't remember the other 4. But if anyone wants to know, I can email them round, or you can go on the NICE website, and all that information is freely available.
All right, and then a question from Jerry Durham. Yes, but what have the guidelines really ever done for us?
Haven't I just told you? I knew Jerry wouldn't agree with me. Yeah, what have they ever done for us? Well, you know, there are different views on what sort of evidence should be used to guide practice, and I'm sensitive to that, and I'd certainly have my position, and I suspect it would be pretty different from Jerry's, and that's fine. There's room for conversations on that. But the evidence base around these treatments is massive, and everyone is looking at what research there is from their own perspective, with their own agenda, in a piecemeal, non-systematic, and often uncritical way, or selectively critical. So the idea that you can get a multidisciplinary group of people funded by the state, not industry, allow no industry involvement whatsoever, have 5, the amount of declarations of interest in there, to really try and give a clean and clear audit trail, it saves you a job that you couldn't actually ever possibly do and is more likely than any other system to get you to some reasonable recommendations. I always think RCTs are the least worst way of measuring whether a treatment works, but they're not perfect. And I think clinical guidelines done well are the least worst way, not the best, the least worst way of trying to guide practice. That would be my answer.
Okay, and then I have another one from Nathan Hers. Do you know of any research evaluating adherence to the wait and see for lower back pain? For example, not going to seek other treatment if that's what is recommended. Any tips on how to increase this?
So I get the first part of the question. I'm not sure I understand not going on to seek other treatment if not going on is what's recommended. Okay. Well, we've got lots of data from usual care arms in clinical trials. But the funny thing about doing nothing is what you compare it to. Is there a placebo doing nothing? Can you compare no treatment to no treatment? So it's kind of difficult. But we know that actually there's an amazing systematic review from Majid Artis's group where they basically took a whole bunch of RCTs for low back pain, and rather than seeing if the treatments worked, they just took randomly one-arm data and plotted it over the next, I think it was 10 months. And whatever group you were in, whether it was no treatment, placebo, usual care, meds, exercise, manual therapy, or whatever else, nearly all of those studies followed the same trajectory. So there is a common trajectory for low back pain. Of course, not everyone will experience it. We're talking about on average. And most of our treatments don't shift that trajectory to a great deal. So I don't know how you design that trial, but I think we kind of know the answer to that question. But this is good news. Most people with acute low back pain are going to do great. A substantial portion of people in chronic low back pain are going to do reasonably well for a time. And most people with any low back pain are going to have it again. Death, taxes, and back pain, right?
Okay. And then we have another one since you did finish early. From Jason Erickson, what are your thoughts on clinical practice guidelines being taught within and applied by unlicensed professionals within their scopes of practice?
So that's interesting, isn't it? So I guess, Jason, what you're asking me is, can people who aren't part of that mainstream community of the licensed professions, should they be using clinical practice guidelines to guide their treatment? Is that the question?
At least being aware of.
I mean, totally. I mean, anyone who's working with people in pain in any profession, to my mind, should be aware of the evidence for that condition. And if we accept that the guidelines are reasonable and we think that they represent a roadmap for good treatment, then I don't see why anyone working in a clinical environment I wouldn't encourage them to use it. Of course they should, absolutely.
Alrighty, so that's the end of the questions. Good job. You get to be done.
Thanks very much.
Alrighty, so we're done a little early, so if we could have a little music. Rajam actually had asked me to ask everyone to switch sides of the room, and I totally forgot. So instead of doing that, because I can see a couple looks of terror, like, do I have to move all my crap? We're gonna move instead. So we're gonna put on a little music. And then when we take our break, we're gonna be back at 3 o'clock. Yeah, 3 o'clock. Okay.